Alrighty. Hello, everybody, and thank you for joining us today for the fifth and second to last episode of SIO's 2021 Wellness Wednesday series. Today, we have Dr. Sameet Kumar with us. He's a clinical psychologist at the Memorial Cancer Institute and Moffitt Hematology and Cellular Therapy program. He obtained his Ph.D. in clinical psychology from the University of Miami in 2001, and he has worked with adults who have cancer as well as their caregivers and families for over 20 years, specializing in palliative care, survivorship, and grief using mindfulness and existential approaches. He is also the author of the bestselling Grieving Mindfully, a compassionate and spiritual approach to coping with loss, the mindful path through worry and rumination, and the workbook, Mindfulness for Prolonged Grief. Today, in Dr. Kumar's presentation, he will address the complexities of end-of-life planning with cancer patients and working with grief after loss. Dr. Kumar, thank you for coming with us today, and you can take it away.
Okay, happy to be here. Happy to be here. So it's always a little tricky to do end of life care presentations because it's not normally seen as a very happy topic, and I'm always happy to provide some sunshine and sunlight on it because it's one of the few things. It's one of the very few things that is going to be completely universal for all of us. This is something that we all are going to experience in our lives before the end of our lives. We probably already know too many people who have passed away. And as professionals who work in oncology, I think all of us will have a lot of very vivid memories and kind of recollections of some of our favorite patients who have passed on over the years. Just by way of a little introduction to myself, I've been doing this kind of work for about 20 years now. I didn't originally set out thinking this is what I was going to be doing with my career, with my life. It's not particularly a field that psychology is known to inhabit very well. And I'm not quite sure why. It seems to have a little more acceptance over the past 20 years than it did in the 1990s when I was in training. But I think it's something that lends itself extremely well to mental health care. And not necessarily in the pathology context of, what are we looking at psychopathology, as much as it is in navigating the mind in the end of life setting. So a couple kind of caveats to kind of guide the time that we'll be spending together on this topic. One is that this is derived from a lot of the research that I've read, but a lot of it is really from my own clinical experience, and really most of the credit has to do with the people who have trained me in this field. Two of them really come to mind right away. One is Frank Ostaseski, who's with the Alaya Institute and with the Meta Institute also, I believe he's affiliated. Frank Ostaseski was one of the founders of the Zen Hospice in San Francisco many years ago during the previous pandemic that we suffered through, which was the AIDS crisis, and taking some workshops with him and in conjunction with Roshi Joan Halifax, who has been doing this kind of work in some measure since the 1960s. So I always think it's helpful to look at people who've been doing this kind of work a lot longer than we have to see what has worked, what's favorable, what's their wisdom, and also what are the pitfalls and challenges that they've experienced. So to kind of start off, I would like to kind of give voice to something that Roshi Joan Halifax has really spent a bit of time on, what she calls the edge states. Now, anytime that we talk about death and dying, and really this is something that always strikes me, even after all these years, is being in the presence of death, being in the presence of people whose health is slipping away very viscerally, very vividly, very visually, and kind of in a multi-sensory sense of being around people who are dying. It elicits, I think, in most of us, a very primal response. And this is something that she calls the edge state. And an edge state is how she defines it, and I think this is a pretty accurate definition. It's a boundary line between the known and the unknown. And we experience edge states throughout our lives in many different ways. And the first day of school is an edge state. First day of training is an edge state. The first time, I think, sometimes meeting with a patient, it can be an edge state, even after all these years. There's this sort of, I think, emotionally charged space of not quite sure what happens next, of what may happen next or what may not happen next. And so we find ourselves kind of straddling this known and unknown, unsure. And sometimes it's a happy space, and sometimes it's a very difficult space to navigate. Well, one thing that's universal about edge states is they tend to trigger a stress response automatically. This is kind of what our minds thrive on. This is what our minds have been created for, is to keep our bodies surviving through difficult situations. And I think really what they're meant for optimally is navigating these edge states. So, that's very different from happiness, which is, I think, what a lot of us who experience our minds feel like we're kind of ripped off. We kind of got ripped off with the minds that we have because we're not automatically geared towards being happy all the time. I think it's important to remind people that these edge states are really what the mind is for. That's what they've been sort of molded to do for thousands of years in natural selection. And so one of the things that the mind does really, really well is stress. It does it extraordinarily well because stress helps to get us out of immediate danger. And so when we're exposing ourselves to these edge states, and as we spend this time together talking about end-of-life planning, I want us to be very mindful and very aware of any of the edge states that we may be experiencing with this kind of content. Do we find ourselves getting distracted? Do we find ourselves kind of wandering mentally, wandering around into some other territories and other areas? It's not that unusual to have that happen. And so one of the things that I find very helpful in managing edge states and managing kind of being present for this kind of content is these mindfulness exercises, belly breathing especially. I think speaking to SIO, you probably all know how to do some belly breathing or some sort of breathing techniques. I do like to kind of put a lot of emphasis on breath awareness when talking about end-of-life planning in grief and resilience in cancer care. Anytime I enter a patient's room, or these days, a lot of it is telehealth, anytime I'm logging on to the computer, I try to take it as a cue to check in with my breath. And I find that this is often left out when we're talking about end-of-life planning. Being present with people who are going through the end of life, going through these milestones that are heralding the end of their lives is extremely challenging. And what I find is that for a lot of people working through our navigating and working through our healthcare system, oftentimes it's very much checklist oriented. Are you doing this, that, or the other? Are you feeling this, that, or the other way? And what they're finding is that a lot of us as healthcare providers aren't really able to be present with them. And these breath awareness exercises that help us to stay present with the content of end-of-life planning, they also help us to stay present for a human connection, which is oftentimes so elusive in healthcare settings. And I think my own experience has shown is that it really does help with generating these conversations leading to end-of-life planning. So can you go to the next slide, please? So these are what we call the goals of care conversations. And oftentimes this is left to the palliative care professionals, but really I think it takes a village. It takes a whole teamwork of professionals to do that. All of us who work in some capacity in integrative oncology, I think we tend to have a lot more of a qualitative relationship with patients than other healthcare providers do. And I really do think that a lot of times it's approaching these conversations with patients. It really is a much more peaceful and friendlier way to do it rather than a stranger coming into the room. Through integrative care, we've usually built up a relationship with our patients that's very unique, very different from other kinds of healthcare providers. There's a certain level of trust that's there and almost friendship, that starts to develop. We have a lot of time, a lot of intimate time with our patients and talking about some of their symptoms and talking about some of their struggles and really approaching their humanness holistically. their totality of experience. And so when we ask questions about their understanding of disease versus talking about what stage they have, what is their understanding of it? One of the things over the past 20 years that has been really quite wonderful is that cancer staging doesn't necessarily mean what it used to. There's a lot more uncertainty, a lot more ambiguity in it. And we oftentimes look at that uncertainty and ambiguity as a stressor, as something that we need to really work through. But in this instance, I think that's actually really wonderful to not know that, stage 4 does not mean that 3 to 6 months and that's it, which is what it universally was 20 years ago. It can mean many months or years, but what kind of understanding does the person in front of us who's going through this illness experience, what kind of understanding do they have of it? Is it accurate or is it inaccurate? That accuracy can work both ways. Is it less hopeful or more hopeful? And I think it's important to not try to feed into this sense of good or bad, but just to be present. And a lot of that begins with our own breath awareness and having these conversations and being present for them. We don't kind of want to bring our own anxiety into the room as much as possible. We would like to just be present with this kind of human connection in addressing these goals of care. So, exploring an understanding of disease versus the staging. What is the understanding of treatment? Is their understanding that this treatment, is their understanding of treatment accurate in terms of not only the goals of treatment, but the duration of treatment and the duration of side effects? A lot of times, a lot of the conversations I'm having with people, they're kind of convinced that palliative treatment is going to be, because it's palliative, it's going to be side effect free, or it's going to have less side effects. This isn't often the case. So again, one of the things that I try to bring to these conversations is a sense of holistic presence. And part of that is not having my own agenda that, I'm going to get this person to sign advance directives today, as much as it is, let's figure out what does suffering mean to this person? And is there a way that we can address, minimize, reduce that level of suffering and maintain dignity? What is meaningful to the patient? There are some people who want to try every treatment under the sun. And although that may not be one of our values in terms of what we would like for ourselves, we have to respect those choices in patients. On the other hand, there is a fair amount of people in this world who would like to try every available option, but also not die while on treatment, but have that period of time of a month or 2 months or 3 months, as predictable as that may be, or unpredictable as that may be, to have that kind of holiday from treatment towards the end of life. And there are goals that they may have that they may not have been able to articulate. The momentum of treatment has its own kind of speed. And I think part of what our role can be as integrated providers is to kind of give voice to the other vast world that may not be accessible to them because of the momentum of treatment. What is known and unknown? Do we know kind of where this disease process is? Do we know where we would like it to be? What is the unknown that this person that we're speaking with, what is the unknown that really concerns them? Is it pain and pain management? Are there providers and specialists that perhaps we can be advocating for that they start to see sooner rather than later? The thing that we really don't like to see is palliative care being brought in the last few days or weeks of life. It's so much more effective to have an advocate like ourselves saying, maybe you should start seeing palliative care right now, not because your symptoms are so severe, but because they may get so severe. And it would be nice to have somebody on board who knows you already and has your values in mind and has your priorities and what's meaningful to you in mind. So I think that is essentially important to do, is to be an advocate for end-of-life planning before it gets to that kind of setting, as much as we can provide. I find that having these goals of care conversations, goals of care usually mean advanced directives. Do you want to sign the DNR, the do not resuscitate, or do you want to be a full code? And I think the goals of care is actually best used as a much wider umbrella term to kind of encompass senses of meaning and purpose in life and in illness. What are the goals of people going through their last few months or years of life? What would they like to do? What would they like to achieve? And, what is the life that they're fighting for in a certain sense? I don't usually like to use these fighting metaphors, but I kind of am at a loss for words sometimes in trying to describe what this is. So I think that it's helpful to think of our role as integrative providers as being kind of voices of reason and balance, and moving people towards a holistic sense of where disease treatment is going, and also what the limitations of those treatments can be. So I think of having these conversations as exploration rather than directive. There's oftentimes consults that I've received, inpatient consults, saying, this person's being unrealistic. They don't have a very good understanding of their disease. You need to get them to sign a DNR because this care is futile. And, the referring providers get very frustrated. They've been working on this issue for 2 or 3 weeks sometimes. And, I'll go in and meet the patient, have a very detailed conversation with them, do, like a full intake, and also talk to them about what's meaningful in their life and try to get a sense of what's driving them in their decision-making. And I may not even bring up advanced directives that first day, but maybe come back the second day and say, it was really good to meet you, if it was good to meet them, and kind of reflect on what they've shared, but also to just start exploring, it looks like things aren't going so good. What's your understanding of it? I keep hearing these things from the doctors, but what's your understanding of it? And when their understanding of it is revealed, to say, is this the place that you want to end your days? If, kind of following the momentum of the conversation, I definitely don't want to be heavy-handed about this as much as collaborative about it. And having those conversations about, is this where you want to be spending your final moments or your final days? Or would you rather be home with hospice care, comfortable at home? Oftentimes people don't want to be home. They don't want to burden people at home, or their home is not adequate or set up for the kind of care that they need. And they might not know that there's such a thing as a hospice contract bed or a hospice unit that they may be able to go to. And I would encourage you to kind of explore, if you don't know, to explore with your healthcare setting, wherever it is that you're working, to see what kinds of options are available for patients, so that you kind of have this knowledge in mind. And so, being able to collaborate with somebody, explore with them what their values, what makes their life meaningful, what makes their end of life process meaningful. It becomes more of a collaborative conversation rather than a directed, this is something that we must do. And unfortunately, sometimes we don't have the luxury of multiple visits and the luxury of time. So I think it's important to kind of always have these in the back of our minds, even the first time we're meeting somebody who has a survivable disease, just to get a sense of what makes them tick, what is important to them, and what would we like our time with them to be. So next slide, please. Okay, so the issues that come up often, and these are the things that I'm oftentimes kind of thinking of, and it's helpful to have this sort of working knowledge intrinsically, just kind of in the back of your mind, that these are the things that we need to really start addressing. The first thing is what we call legacy work. And this is very challenging to do, because what we're basically doing with legacy work is talking about what kinds of physical objects, physical reminders, tangible things do we want to leave behind for our loved ones. And sometimes this can mean letters or cards. I've had some patients fill out cards in advance for milestones for their children that they won't be there for. I'm going to be completely honest. If I bring it up 100 times with patients, I probably have 10 who actually complete it. It's very challenging to do this kind of thing. And it's not the kind of thing that most of us have done. In the event of my sudden and untimely death, here's a card for my kids' high school graduation, for their college graduation, for their wedding, for their 21st birthday, or their 50th birthday, or something like that. It can be very challenging to do. But I think what else we can kind of pair it with is bureaucracy, which is the main sort of end of life and grief rituals set that we have in our culture. There is a lot of bureaucracy to be done, and I do try to frame it this way. When I'm meeting with somebody and they're in a state of acute stress about the cancer diagnosis or restaging, there's been a different sort of movement in their treatment, their disease has advanced, or treatment has not worked as well as we had hoped it would. There's a change in their health status. Those changes, as much as they are edge states, these edge states provide a window of opportunity to start addressing things. I'm not too shy about asking people, sorry for the bad news. Just kind of want to clear the air. Do you have a will? Have you worked out what happens to your estate after you pass on? And it's not kind of, I think a lot of providers are reluctant to go there, because it's kind of like, doesn't that mean that I'm telling the person they're dying? Well, not necessarily. Usually what I'll do is I'll tell people that, you should probably have that done anyway. We should all be doing wills. We should all have estate planning taken care of when we get married, or when we have children, or when we get a new job, or a new insurance policy. We should have those things worked out anyway. Otherwise, it's anywhere from $3,000 to $7,000 in probate court, which can lead to 6 months of very exhausting litigation after a loved one has passed away. And so what I'll tell people is that, I'm confident things will work out. They usually, with the way treatments are right now, they're getting better and better. But I'll tell people that, this is a window of opportunity. I think it would be important to get your will taken care of so that you don't have to think about it in the future. And if people are getting really bad news that, they are terminal, there is a very short amount of time. I think it's helpful to just say, I think it would be important to at least meet with an attorney and get a will taken care of. Some of these are just templates that they can sign. Anything's better than probate. Switching house deeds or car deeds and things like that, taking care of accounts in advance. These are all the kinds of minute details that can be so aggravating for loved ones after the death of somebody that they've really cared for. People don't oftentimes think about these things. And I think it's helpful to be these advocates of holistic care, that, we should be able to address some of these bureaucratic concerns. One of the unique qualities about my role in the cancer center is I do get to work with caregivers quite a bit. So I can have these conversations with caregivers, make sure your accounts are in both your names and it's not an and, but an or, so that you don't need to kind of pack up 10 different forms of ID and a death certificate and all this stuff to handle all the bank accounts and things like that. Certain banks are more friendly than others about loss and grief. Some of them are absolutely cold-hearted about it, and they just add to the burden. So it's best to have these things taken care of beforehand. And again, it's not necessarily a morbid topic. With breath awareness, if it's brought up in a stressful way, it's extremely stressful. If it's brought up in more of a soothing, matter-of-fact, hey, I'm sorry for the bad news, but maybe you should get some of this stuff taken care of. Confident you may come out of this low point right now, but in the event you don't, it would be nice to have this stuff taken care of and not have to think about it again. Most people respond fairly well to that. I have to add, though, the best intervention I found for end-of-life planning is to engage in our own end-of-life planning, our own as healthcare providers, to have that taken care of, to have our advance directives taken care of, to have our estate planning done. And there's really no substitute for that. And so, being able to even share with people that, when I wrote my will, when I did my will has like this line on the last, there's a conversation I just had this morning. There's space on the last page that I can add kind of any addendums for specific objects. Maybe you want to start thinking about doing that. And, kind of just shedding light on things that we'd rather keep dark. I've been, I was about to say I've been surprised over and over again, but at this point, I'm no longer surprised. People are actually generally relieved to have these conversations, because they're sort of like the dirty little toxic secret that if I give voice to it, it's going to make it real. It's going to make it happen like a magic spell. And it's not true. It doesn't work that way. In fact, what I find is often the opposite. When people are talking about end-of-life planning with providers such as us, who are interested in their holistic well-being, into their integrative care, this is kind of what we do. We're sort of outside the box in so many ways. So people have a deeper level of trust with us, I believe, than they do with a lot of other people on their healthcare team. And that isn't to dismiss those other specialists as much as it is to elevate what our role can be in end-of-life planning. There's a certain level of trust that's there that if we start speaking about these things with them in calm, soothing ways, matter-of-fact ways, this stuff has a lot more, these tasks have a lot more likelihood of being done in a timely manner, which can make the end-of-life process a lot more peaceful, a lot less disruptive, certainly a lot less conflict-oriented between family members if this stuff has already been taken care of. So, potentially, these conversations that we're having with people, and I don't think I'm being dramatic here, they can affect generations of our patients' lives and generations of their family members afterwards. Because think about how many families get severed because there was no will. How many family ties get disrupted because there was no will, and it turned into a lot of infighting between siblings or cousins, and they never spoke to each other again. And this branch went off to this country, and this branch stayed in this town, and they never saw each other again. That's happened for thousands of years. And these simple, soothing conversations have the potential to prevent that from happening. So, it's not just the patient in front of us that we're helping. It's their families, their descendants that they haven't even met yet, that they haven't even been born yet. It's their descendants that we may be able to help also. So, the bucket list gets a lot of attention during the pandemic, it's been hard for a lot of people to achieve their bucket list. So what is the most attainable bucket list? What are those things that we would like to do before we leave this world? And what can be done to attain them? What can be done to pursue them? Some of those things may not be realistic anymore, but what's the next best? So instead of kind of navigating towards the ideal or the perfect, I always like to think in terms of best possible. That's one of my operating phrases that I have in mind for navigating end-of-life issues is what's the best possible? Are there religious rituals that need to be done? The anointing of the sick or any other kinds of religious ceremonies that need to be taken care of sooner rather than later. And, I think what speaks to a lot of us in integrative care is the setting. We really do place a lot of emphasis in many religious and spiritual traditions that the moment of somebody's passing should be as pleasant as possible to direct the soul to the afterlife. So does this person in front of us who's going through this process, do they have a belief in an afterlife? And are there things that we need to kind of advocate on their behalf for them to do? Aromatherapy, music, any sort of spiritual practices that they should be engaged in, or prayers that need to be said, or chants that need to be playing in the room. They can kind of share these things with us so we can be their advocate in the end-of-life setting if we have that ability to do. What is the kind of inner work they need to do? I'm going to pay a little bit more attention to that shortly, but I think it's helpful to kind of get these things taken care of. A lot of times I do recommend that people begin a meditation practice with their cancer diagnosis. And there's a belief among a lot of spiritual beliefs that have this, that a meditation practice is the best preparation for the end of life, as much as it is for managing the normal stressors of life itself. So, there's a synergy there that the things that help us live a better life help us die a better death. There is this saying in the hospice world that I think rings true. It will continue to ring true for the next 1,000 years is you die as you live, meaning that people tend to go through the end of life as they went through their life. So if we can kind of cultivate some of these spiritual practices that are soothing, uplifting, and hopeful, and remember, we're talking about uplifting and hopeful in the context of dying. There's still room for hope at the end of life, hope for comfort, hope for relative pain-free passing, and hope for peace and harmony among our family members as much as possible. Hope for a peaceful setting, hoping for dignity. There's so many things to hope for in end-of-life care that I think a lot of times people see it as hopeless. I actually see it as the opposite. I think it is one of the greatest opportunities for hope, and potentially one of the greatest impacts that we can have on people is in dictating kind of their setting for end-of-life moments. A lot of times, what's also in my mind is that research has shown fairly consistently dying in an intensive care unit is extremely traumatic for family members. So we do want to, as much as possible, try to avoid futile care as much as we can. I feel like I could have a whole separate talk about COVID and COVID-19 and, dying in an intensive care unit on FaceTime is a whole other level of things. And I think some of that research is already starting to come out to show just how damaging and awful that process can be, not just on patients and their families, but on us as healthcare providers, on the nurses who have to use their phones and iPads to have these very difficult conversations at all hours of the day. And I don't think it gets easier at all. So, kind of taken together, there are tasks and settings that we can address as integrative care providers for people that really, I think, can make a huge difference, a huge impact, not just on our patients, but on their generations and descendants that will come afterwards. Next slide, please. So a lot of times what I recommend people do is have these conversations. These are called the 5 things. And these were devised by Ira Byock, one of my favorite writers, authors, human beings in general. He is really, truly a hospice pioneer. He has a great book called The 4 Things That Matter Most, and it's based on some of these writings of his. The 5 things are the reason I still carry pen and paper with me. When people ask, I don't know what to say to my mother, my father, my brother, my sister, my wife, my husband, my friend who's dying in the room there, I'll take out the 5 things and I'll say, try these themes, say them in however words you want to, but just try to make sure that you say these words in some capacity. And these 5 things cover the themes that Dr. Byock, and I think it's actually derived from the Hawaiian Ho'oponopono traditions, the kahuna traditions out there. How it would happen in Hawaii is when somebody would be sick, the village would have a conversation with this person to try to correct any of the sort of unfinished emotional and spiritual baggage that may be directed at that person contributing to their illness. Well, Dr. Byock took those 4 things and he added the goodbye, which sometimes I'll put in parentheses. So these 5 things, these are the themes to cover in any relationship that's ending, whether it be through death or breakup or any sort of loss. I'm sorry, I forgive you, thank you, I love you, and goodbye. And sometimes people struggle with some of these. I put goodbye in parentheses because with modern medicine, it's hard to know exactly when goodbye should be said. There are so many goodbyes, I think, that we do say to people that it's hard to know which one has the finality, all the kind of the ultimate goodbye. I also feel that when we bring up these 4 other pieces, the goodbye is almost redundant because we've kind of taken care of the unfinished business that we may have with this relationship. It's not to say it's not going to hurt afterwards, but it's nice to be able to say these things to our loved ones while they're alive. Before they've passed on. So I'm sorry can cover almost anything. If you're Canadian, you're used to saying I'm sorry almost maybe 100 times a day. But I'm sorry can cover almost anything. And it can be whatever happened most recently. It can be for everything in general. Similarly, I forgive you can be for little things. There are some things that people do which they really strain our ability to forgive. And I try not to push people to do this unless they're ready for it. Thank you and I love you, I think are pretty straightforward. I have to add, for a lot of relationships that are very complicated, this exercise might not be appropriate, in which case I will recommend that people do this as a journaling exercise months or years afterwards if they want to, if they feel like there's a sense of unfinished business or difficulty in kind of having this ongoing relationship with somebody. And in that event, this can be a journaling exercise for afterwards if it was impossible to share this content with somebody while they were alive. It's tremendously therapeutic whenever it's done, however many times it needs to be done. It can be incredibly enriching and invigorating to get this kind of emotional baggage out of the way. This is also appropriate for somebody who's dying to have with their family members as a way of kind of cleaning the slate And, this can get very tricky. Not everybody's a good person in this world. And it may strain some family members to accept an apology or to accept forgiveness from somebody who's done them really, really egregious harm. So this is a suggestion. It's an attempt. I think these are goals that we can try to do for somebody and to try to facilitate for families to engage in. I've found them to be very helpful, but I also don't think that this is a cookie cutter that we should inflict on everybody equally. And next slide. And just kind of touching on grief a little bit, I think it's helpful to kind of delineate different types of grief that we experience as human beings, as healthcare providers also. Anticipatory grief is something that is, I think it's being paid attention to more. It's the sense of not knowing exactly when something bad is going to happen, but knowing that it will. Oftentimes this begins at the moment of diagnosis. It may begin the first time we meet a patient and we know kind of the rough trajectory of what their illness course may be. It's something I think that we should keep in mind. Why do I get so challenged when I'm seeing this person? Why is it so difficult and stressful for me? It's anticipatory grief. There's something about giving a name to these things, giving a voice to these states that makes them just a little bit more manageable, which can be incredibly helpful. Cumulative grief. This is something that we're in healthcare experiencing a ton of these days with COVID. This is the accumulation of losses that we carry around within us, not just of our friends and family members, but also of our patients. I think in some ways they kind of all go into the same bag. There's certain times of year that we re-experience all the losses that we've suffered through. Somebody you were particularly close to has passed on and their birthday rolls around. It might not just be that we're missing them. It might be that we're missing everybody that we've lost in some capacity. Oftentimes there's just this one patient who triggers such a sense of closeness to them that when they pass on, we experience the losses of all the patients we've ever known through this one loss. And I think it's important to give that a name, to understand what it is, and to welcome it. And I don't think these are pathological processes. These are natural events. These are natural processes that happen with us when we care. Complicated grief. This is the most common type of grief, although epidemiologically it's not supposed to be. The reason being is because the normal course of grief is supposed to be 3 to 6 months. In my experience, the first year of grief is really orientation. Oftentimes for people, the second year can be a lot more challenging because it's kind of like the reality of it starts to sink in. The vastness of time starts to take hold, and we start to realize that our loved one is never coming back. And it can be very challenging. Finally, if there's one thing that I hope everybody remembers, is that grief is nonlinear. It doesn't go in straight lines. Stages aren't discrete steps that we kind of go up one at a time and then never go back down again. Grief is very nonlinear. I think it works in circular time, which is very, I think, more of a holistic worldview. It's more cyclical than linear. So our calendars are linear, our work schedules are linear, the school calendar is linear, but emotional states are not linear, they're cyclical. And so grief works in cycles, and we re-experience loss over and over and over again. And that's not because we're not doing it right, it's because that's the way grief is. And I think meeting it with breath awareness, with stress coping, is about all we can do to manage some of these very intense and difficult emotions. We have to be very careful when we're talking to people who are going through end of life or who have gone through end of life of a loved one and are now coming to us for help with grief. We have to be very careful to avoid linear language. Phrases like getting over it, getting through it, moving to the other side of it. Oftentimes they don't speak to the emotional realities of what grief can be like. And oftentimes they don't speak to the realities that we ourselves are experiencing as healthcare providers. Unfortunately, we don't really have, I don't think, an adequate vocabulary, at least not one that's culturally accepted, to help navigate this terrain. But the best we can do is keep trying with an open heart and open mind, keep trying. I think I would like to open it up to some questions right now. We have about 15 or 20 minutes left. So I don't know if there were questions submitted prior to the talk, or if people would like to chime in. I'm open to anything.
if anybody has any questions, feel free to unmute and ask them live.
I don't really have a question. I just wanted to say that I love the idea of bringing in the breath for end of life. I had an experience last week in the acute care unit of a hospital where I provide yoga therapy, and the patient was end of life. And I made a connection with a family member who was there. And the patient was, struggling just with the whole situation. It was a struggle. I could see she was struggling with her breath. And the family member, when I engaged her and kind of got them in a little bit of maybe a trio of like breathing and just awareness of what was happening, the daughter started crying. And I was just talking about the beautiful way everything was happening in the room. It was just like supposed to happen that way. And I told the patient or suggested that she soften her belly and soften the breath. And it happened very naturally. She just kind of smiled and started breathing a little more softer and slower.
Yeah.
And the next day I heard that the patient died, and the daughter called me and said that as soon as I had left the room, the patient just went into, just stopped talking and went into a coma, and kind of it became less of a struggle, and the death process was very easy.
Yeah.
So I just wanted to say I just totally related to what you said about the breath. It was so miraculous.
That's so beautiful. You're describing transforming this acute care setting from tension and stress to something radiant and natural, right?
Absolutely. Yeah. It was, and it made it doable.
Yeah. Wonderful. Wonderful. Thank you for sharing that.
Anybody else have any questions? Oh, Jody?
I do. Hi, Dr. Kumar. Thank you so
Jody.
much for that.
Sure.
I do have a question. How is it wisest to approach family members and even the person approaching death when nobody wants to talk about it? When not necessarily when there's a denial or, they want continued and maybe, like you said, futile care, but just when the family's not used to verbalizing anything so real, deep.
Yeah. So a lot of times what I'll do is I'll say, I was reading through the chart and I read this thing and I wanted to kind of bounce it off of you. What do you think of that? Have they told you this? And just kind of start exploring with them and collaborating with them that, I spoke to your doctor and this is what they said. And do you feel like that's accurate? And just kind of break the ice that I'm not bringing this news to you. And I just kind of want to know where things are at right now. I'm not saying this is what it is. And that can, a lot of times it can sort of come across it not so directly, because a lot of patients and family members will kind of say, we're not talking about that right now, or we're not going to be talking about that at all. There are some people who, I hate to say this, there are some people that I just cannot make any headway with at all. And they'll say, I don't want to talk to that psychologist ever again. Make sure he doesn't come in my room. That does happen. Not very often, but it does happen. And, actually, a number of times they've kind of changed their minds after a while. But this is one of the challenges of trying to meet people where they're at is sometimes so unhealthy and so toxic and so self-defeating and self-destructive that we just feel helpless. And we're just watching these people go down a path that is completely avoidable. and a lot more painful. Usually what will happen, and this has been the challenge over the past year and a half with COVID. I'm in South Florida, so you may notice I'm at home right now. Our hospital is full. Actually, the only units we have still operating are a bone marrow transplant and labor and delivery. Everything else is now COVID. So, along with that is visitor restrictions. And before, we used to be able to have a lot of family members in the room at the time. And now we don't. We just have one, if any at all. And it's very challenging to do this over the phone versus in person when you have like 6 people in the room and one of them goes, hey, let me talk to you outside the room. And they're the one who can kind of leverage with the family and they're being more realistic. We've lost that now. So it's just either the patient or one loved one or a whole slew of people on the phone who have no idea who you are. They can't see you. They've never met you.
Wow.
So it poses its own challenges that way. But I would say is that, a lot of times consulting specialists, people who pull us into these rooms, they want things done right away. And I have to constantly remind myself that I'm here for the patient. I'm not here for the attending, And so that kind of urgency that say the attending or the oncologist is experiencing, it kind of stops at the door. And when I'm with the patient and the family members, my role is with them. And, these specialists may have been trying for 2 or 3 weeks to have conversations about care. If I can get it done in 2 or 3 visits, that's impressive, very impressive. It might not be quote unquote fast enough, but I think it's just trying to make that human connection and, this breath awareness of being the soothing presence in the room. Most people do start to open up and start navigating these sort of edge states when they're in the presence of somebody who's watching their breath, who's, feeling grounded and centered and not getting kind of battered around and responding to stress and tension. Instead, they're just being present. It kind of makes it safer to navigate some of these sort of undesirable, difficult areas.
Wow. Thank you.
You're welcome. You're welcome. There's a written question. How do you...
Go ahead.
Oh, I got it. How do you work with an uncommunicative patient who's in a coma state at end of life? Presence. That's really all it is. Sometimes, this isn't, as a psychologist, I usually can't bill for that visit, but it really is. I think it's an honor. It's a privilege to be present at the end of life. For me, my own personal belief system is that, I'm bearing witness to somebody's soul, which is something that we can't normally do in, going to Costco or going to the grocery store. I mean, they're there, but they're a little well hidden. So it is an unbilled visit on my end. And sometimes what I'll do is silently say a prayer over them. Maybe I'll whisper in their ear if I've had a relationship with them. Hey, it's Dr. Kumar, your psychologist. You're in the intensive care unit, orient them. You've gotten a lot sicker. You have a breathing tube. Don't fight the tube. The doctors are going to try to do whatever they can, but you're being very well taken care of. Try not to be scared. And if there's anybody else in the room, if there's loved ones in the room, I'll orient them and try to encourage them to also speak to the patient. We don't know if it's true or not. I think it's mixed. Oftentimes people can still hear, even though they're not responsive. They can still listen to us. Definitely think there's always a room for aromatherapy and music, no matter what the level of communication is. One of the things that I really enjoy doing is turning those damn TVs off in intensive care units with non-responsive patients. The last thing they want to be doing is watching the news, cable news. So if there's loved ones who can put in, meaningful music, the kind of music this person used to like to listen to. I've done that for patients in the past, is, pulled up music on my phone that I knew they liked and just kind of, they can't talk to me, but I can play them a song, that can be helpful. But yeah, that's a non-billable visit. That's just out of, that's good karma points.
I also wondered, you remember last year was when the pandemic hit, You were part of a webinar and you spoke a lot about how mindfulness can help healthcare providers. And all of the months since then, I just can't imagine, like you said, the accumulation of losses. And now with this fourth surge with the Delta variant, can you speak to other healthcare providers who might watch this on YouTube as to, there might be more anticipatory grief, right? Because
anticipatory and cumulative. Yeah.
Right.
Yeah.
Right.
Yeah.
Can you speak to that and some habits too that can help?
Absolutely. Absolutely. The most rapid way I know to address acute stress is 4-7-8 breathing, inhaling for a count of 4, holding it for a count of 7, and exhaling for a count of 8. I think there's something about cumulative grief that brings an acute urgency, as if we have to kind of fix everything all at once. And I think certainly working in COVID has been day-to-day panic is what it feels like for most people. And I think one of the challenges is to try to remind ourselves that healing takes a long time. It takes a very long time. And we're not doing it wrong if it's taking a long time. We do have choices in how we heal. And I would encourage people to try to do it as sober as you can. Try to do it as healthy as you can. But also, don't be so hard on yourself. Reach out for help. Reach out for help in any modality that speaks to you. Maybe psychotherapy is not your thing. Maybe what you need to do is take up running or yoga or make some changes in your diet. Any small thing that you can do will be a drop in the bucket. That those drops do add up. It just takes a long time. And just because it's taking a long time doesn't mean you're doing it wrong.
Thank you.
Sure.
All right, we're almost at the top of the hour. Dr. Kumar, do you have any other final comments or anything?
I would just say that anybody who is finding themselves in an end-of-life care setting, I will close with the words that Frank Ostaseski and Roshi Joan Halifax use often. Maintain a strong back and a soft front. Watch your posture and watch your breath. They really do make a big, big difference. And I thank you for your time.
Thank you so much. Thank you, everybody, for joining us today. Have a great day.